Good afternoon, ladies and gentlemen. My name is Dr. James Lyons-Weiler. I'm coming to you live from the WWDNYK studios in Pittsburgh, Pennsylvania. This is a first in a 6-part series on ending the pandemic. Everyone knows what I'm talking about. I'd like everyone who has begun watching this to please tag 2 friends. This is probably one of the most important presentations that I've shared with the community, and we're going to sit back and relax. If you can't get through the whole thing, we might go 2 hours, we might go 3 hours. We'll see how long it takes to get through the material. But today, what I'm going to do is I'm going to go over Cdc'S deadly testing fiasco. And the way we're going to do this is by starting with where we stand today on the outbreak. At this point in time, today, we have 45,000 confirmed cases, and immediately the people who have been on top of things are thinking, how in the world are these 45,000 confirmed cases confirmed? And that's the topic of today's presentation. We have the CDC providing information compiled from all of the states. They have a laboratory response network partners in preparedness program. And this program brings forward information, coordinates testing, or is supposed to, for emerging pathogens. And it's very well funded. In fact, the CDC as a whole in 2018 had a budget of $11.9 billion. And one would suspect that an organization like the CDC, with the reputation that it has, with the authority that the CDC carries, that they would actually be on top of things when it comes to an outbreak. Unfortunately, as most of America should know, but probably doesn't yet know, and it's up to you to make sure everyone who can know comes to learn through this video, that America needed this coronavirus and that the government failed. I'm going to go into details, and I'm going to be reading articles to you, and I'm going to be playing videos as we go along. This is the Wall Street Journal publishing this. Scientists warn that we may need to live for social distancing for a year or more. It's not the kind of thing that Wall Street likes to hear. It's not the kind of thing that children who can't go to school and parents and people who like to get back to their jobs and who like to have their income, be able to pay their bills, would like to hear. And in America, in the United States, we're definitely focused right now on how soon we can end the epidemic. Well, I haven't even yet mentioned the people dying from this, and that's a sad thing. It's a sad thing to focus on the finances when in fact we have people dying, absolutely dying from the coronavirus. Now, I also know that there are people who are going to say, yes, but people die from many things. And I hope by the end of this presentation you're going to see that people are going to die unnecessarily, absolutely unnecessarily, as a result of one key decision, that we have to hold those decision makers accountable. We know from studies from China, like this one that was published in Science recently, that there is an asymptomatic period, and that asymptomatic individuals are responsible for the bulk of the transmission of this virus. This is what distinguishes it from every other virus, that respiratory virus that we've had to deal with. The asymptomatic period is estimated to be 4 to 5 days. And the Chinese study here also shows that 86% of cases were undetected by their surveillance. And you know what an information society China is, you know how they went into lockdown. Even with the lockdown, 86% of cases were undetected. And they did bring testing in the middle. So we have to take a look at what that means in terms of our numbers when we're told there's 45,000 cases. This is a chart from that study that shows that the impact of undocumented infections in the transmission of SARS coronavirus 2. And I happen to have had 2 conversations with 2 medical doctors who I respect, who say that they're treating coronavirus patients. And they say that they're not testing them because if they test them, their facility would be shut down. And so when we look at this rate of spread and what's happening, it is illegitimate to assume that simply because you don't have symptoms that you're good to go. You have to look at yourself as a person, a point person who could be the apex person that could lead to, I don't know, 100, 1,000, 10,000 down the road, maybe 1 million new coronavirus cases. And we'll get into the numbers of comparison to influenza later. It's an important comparison, and I'm going to outline for you why that comparison is so difficult. But if we correct for the estimated undetected using the 86% as a model, it's the only model that we have, unfortunately. The 45,000 cases that we see that are confirmed in the United States, they're presumed positive because they don't test for anything else, and yet they have all the symptoms required for a diagnosis of COVID-19. If we correct for 86,000, then right now, as of today, 3/24/2020, we're looking at something like 325,000 undetected, well, total detected and undetected cases in the United States. And we'll get to the recovery in all of that and how that factors into what these numbers look like right now today. But for now, just understand that if there's 86% undetected, then we have a problem. And the nation right now is in virtual shutdown. State by state, they have varying degrees of shutting down the country to try to pause for a moment and say, what's our next step? How do we go from this situation where clearly we've gone on an exponential rise very early in the outbreak? We've went into an exponential rise. How did we get there so quickly? In my modeling, which I've done in the past for other outbreaks as well, I expected that since we were the United States and we did shut down borders and stop travel, and we do have the CDC, and that they would very easily develop a test. And testing is key early on in this. That we would have weeks and weeks of time. I was clamoring for not touching hands, not putting your hands above your head. I was clamoring for sanitation of public surfaces. And please, if you go out in public and you gas up your car, take some antiviral wipes with you and wipe down the buttons, and go around the other side of the pump and wipe down the other side of the buttons too. It's really a very filthy place when people are touching their hands and then they go through a drive-thru and grab some food. That's probably where a lot of the spread is coming from. But this 86%, if it's not 86% and you're skeptical, then what is it? We know that there's a percentage that are undetected. Let's say it's somewhere between 50 and 86% of cases that exist in the United States right now. So even at 50%, we're looking at something like 200,000, approaching 200,000 cases. When it comes to the comparison of influenza, this is made problematic by a number of factors. So if the COVID-19 real are those that are confirmed, and the COVID-19 real plus 86% not detected, and this was plotted a few days ago, that's why just a few days ago, you can see it's only 45,000. That was just a few days ago. And you see that the prediction came true. Now we're at 45,000, okay, that are starting to show symptoms. That's, first of all, a validation that there are many that were undetected because they hadn't yet developed symptoms. But among those that were undetected, they absolutely had many that would not go on to develop symptoms. 80% of cases are expected to be mild cases, and people might not attribute it to coronavirus. But on this chart, I also plot the real data tracked by CDC year after year on influenza A and B over the same time period, starting in October. So this is the first 45 days of the outbreak, and the influenza A and B are the first 45 days of the flu season. And there's an argument going on, or discussion, I should say, about is coronavirus just as bad or just as not as bad as the influenza, and that it's not a big deal, and that we're overhyping this, and that we maybe can all just go back to normal and not worry about this because it's not like influenza. Well, you'll see that this is a very difficult question to answer, and you'll see why. And you'll see what we have to do to try to start to be able to get to some answers as a result of us needing these kinds of data. It's a very, very important question. The public needs a frame of reference about what they're dealing with when it comes to outbreaks. So this is a news article from Fox that covered the 86% of all of the COVID-19 cases that before January 23rd that were not at the time detected by public health authorities. And it says that it doesn't mean that these cases were asymptomatic, but it means that some of them were asymptomatic and some weren't. But it's estimated that the undiagnosed cases infected 79% of the total cases. And that's what the study says. The study says that there's a huge, huge, huge number of transmissions from undiagnosed cases. And that means aggressive testing is very important, so that a person can be told that, yes, you do have the virus. Yes, you individually need to stay home. And that's incredibly important at the onset of an outbreak. As an outbreak proceeds, of course, then the testing becomes, if it's done very well, becomes essential in helping to shut things down. There's going to be cases that are not tested, but we'll see how essential testing is throughout this. Because in the medical resources that are projected to be needed under this exponential growth, under the worst case scenario and under the moderate scenario, there's 920,000 available hospital beds in the United States. Under a moderate outbreak, throughout the course of the outbreak, it's estimated that we'll need 1 million hospital beds. Under a severe outbreak, it's estimated that we might need 9.6 million hospital beds. That's 1,000-fold to what we have. In terms of intensive care units, in the United States, it's estimated that we have 68,000 intensive care units. Under the moderate outcome, this is a study by Johns Hopkins University, under a moderate outbreak with coronavirus, we might need 200,000. Clearly, we don't have enough. Under severe, we might need 2.9 million intensive care units. I could go into the pathophysiology of the virus and tell you exactly what I think is happening in the lungs. I have a manuscript under review right now, a study that shows that in all likelihood this is a nefarious virus, specifically because it induces autoimmunity among multiple proteins, including some in our immune system. The ventilators that are at the most severe cases, where you need assistance breathing and oxygen support, there's 168,000 available. Under the moderate condition, moderate outcome, there's 740,000 that are needed. And we don't even want to know how many under the severe. So if we look at this exponential curve, it's just a curve. We've looked at exponential curves for, a couple of months now. I've been looking at it for 4 months. I've been tracking it since January, February, March. Well, 3 months. And in other countries, there's a lot of data resources out there, and they're very well done. And I encourage you to visit them and take a good look at what's happening in other countries. And I'm going to show you what's happening in other countries that do have testing. The estimated and detected being 300,000. The key question then becomes, what is the serious and critical illness rate? And there are apparently two forms of the virus. There's a slow form and a fast form. I call them the S and L genotypes out of China. And these two types of the virus, we don't know what percentage of people in the United States have the S form, and which type, and which percentage, or what percentage of people who are affected in the United States have the L form. We don't know which clusters involve the S form or the L form. And we're nowhere near that level of technical ability in the United States. And it's a serious problem, because we can't really predict, is this going to be 10%, 14% serious illness? Is this going to, that would be moderate to severe, 14% serious illness. And you saw the numbers under both of those assumptions. Is it going to be 6% need ICUs or 3%, 2%? We don't know. And, there's two ways to look at risk factors. One is to look at a risk factor and say, well, the risk factor explains it away. There are people that smoke, so I don't smoke, I don't have to worry. There are people who are old, and I'm not old, so I don't have to worry. There are people with diabetes, and I don't have diabetes. It's becoming increasingly difficult in the United States to say that, as something like 45% of Americans have metabolic syndrome. So there's the other way to look at it is, well, wait a minute. Yeah, a lot of people who died in other countries had pre-existing conditions, but almost everybody in the United States has a chronic illness now. Almost all of us have a chronic illness. So it does us no good in terms of what happens to the medical infrastructure to kind of wish away the reality and say, well, it's not of a risk to me because I'm healthy. I don't have to worry. God forbid in 2 months, somebody who thinks that they're healthy and they don't have to worry needs the intensive care unit because they were in a car accident. We're already at peak capacity in hospitals just every day. The hospitals are not overbuilt for capacity. And we have to take a good close look at what it really means, that it's not a worry because you're not at risk. You are made to be at risk if there are people in your life that have diabetes, or people in your life who smoke, or people in your life, right? Because you become a casualty yourself. Survivors of disasters are also casualties. So we have to take a good close look at being flip about this and saying we don't have to worry and, be responsible and do our part. But what does that mean? Our society is grappling with it. China has dealt with it their way. Other countries have dealt with it. Hong Kong, Thailand, South Korea, Germany, because they have key information. We're left like children in the wind, in the wild, where we don't know which way to go because we don't have accurate testing. And I'm not the only one saying this. I'm going to actually read to you this Politico article. It was published on the 6th of March in 2020. It's written by Joanne Kennan. On Saturday, January 11th, the article begins a month and a half before the first COVID-19 case not linked to travel was diagnosed in the United States. Chinese scientists posted the genome of the mysterious new virus, and within a week, virologists in Berlin had produced the first diagnostic test for the disease. Within a week, January 16th, 17th. Soon after, researchers in other nations rolled out their own tests too, sometimes on different genetic targets. What I mean by genetic targets is that these tests, these PCR tests, make multiple copies of different genes. So if I design a test against the spike protein, I'll have one test. If you design a test against the N gene, N as in Nancy, you'll have another test. By the end of February, the World Health Organization had shipped tests to nearly 60 countries. The United States was not among them. By the end of February, we're in March, it's March 24th. Why the United States declined to use the World Health Organization test even temporarily as a bridge until the Centers for Disease Control and Prevention could produce its own test remains a perplexing question. And it goes on to say, and key to the Trump administration's failure, but you'll see that that's a political statement that it's not worthy of the ink that printed it. It's not worthy of the electrons pushing those letters onto my screen right now. the Trump administration's failure to provide enough tests to identify the coronavirus infections before they could be passed on, according to political interviews with dozens of viral disease experts, former officials, and some officials within the administration health agencies. Early on, the health agency officials that they're referencing tried to blame President Trump for the release of people from the cruise ships. We'll see that that's absolutely, abjectly false. The slowing down of the testing regime, which administration officials acknowledged this week, the slowness of the testing regime, it wasn't slowness, it was an abject failure, is still not producing enough tests to meet the national demand. That was the first among sweeping of many failures. So far, there have been confirmed cases in at least 23 states. We now know that there's 50 and so on. Stock market plunge and so on. But neither the CDC nor the Coronavirus Task Force, chaired by the Vice President Mike Pence, would say who made the decision to forego the WHO test, the World Health Organization test, and instead began a protracted process of producing an American test. It's not a protracted process to make this. The Germans showed us how easy it was. It's not complex. It's remarkably trivial and simple to make a PCR test. That's both sensitive, which I'll define later, and specific to the target. It was further delayed by manufacturing problems, possible ink contamination, and logistical delays. We're going to get into that in great detail. Senator Pat Murphy asked, please provide an explanation for why the COVID-19 diagnostic test approved by the World Health Organization was not used. And that was in a 3.5-page letter on the testing fiasco to Pence, CDC Director Robert Redfield, and the Food and Drug Administration Stephen Hahn. So far, none has been provided. We're going to get to the bottom of that. So, there's a quote from CDC Stephen Redd. We developed a test very rapidly after China produced the genetic sequence. We are in the process of validating that. All right, that was at the beginning of this month. And you'll see by the end of this presentation that we're nowhere near where we need to be. This was CDC Stephen Redd, a 30-year veteran of the agency, at a recent briefing. Azar, who initially led the White House, has now been sidelined by Pence, who also kept defending the testing regime. We've actually been progressing it on this, on par with our peer countries, he told reporters recently. This article is an older article. Okay. We have politics. At this time is when politics reigned. Reason was put to the side and politics reigned. Here is the test from Germany. This was the manuscript that the CDC downloaded. I'm sure they downloaded it or were given a preprint of it before it was published online. Berlin, January 17th, 2020. January 17th, 2020. There's a link to a peer-reviewed publication on this, and I've actually sent that to the FDA recently, and we're going to talk about my communications with the FDA about this. The Germans were so proficient at what they were doing that they actually provided the primer list on January 17th, a week later, and they also published the primer. They published the primer set, so our scientists had access to the exact primer probes that they could have used. This is a matter of email. Someone simply has to email this to all the manufacturers of tests in the United States and say, this is what we want you to use. But instead of adopting the German test on January 17th, the decision was made that CDC was going to make their own test, and further, through the emergency use authorization, once CDC acquired emergency use authorization, which I think was 3 days later, that was restricted to the CDC's test, and there was a delay before the FDA actually would allow other tests to be used. I'm going to read the abstract from the peer-reviewed publication published January 23rd by the German team in Eurosurveillance. And this is science at the speed of light. January 2 months ago, January 23rd, my friends. The background, the ongoing outbreak of the recently emerged novel coronavirus, this is when it was called 2019 nCoV, poses a challenge for public health laboratories as virus isolates are unavailable while there is growing evidence that the outbreak is more widespread than initially thought. And international spread through travelers does already occur. We aim to develop and deploy robust diagnostic methodology for use in public health laboratory settings without having virus material available. Methods. Here we present a validated, and that's the key word, validated. In diagnostics, validation is everything. If you haven't validated your diagnostic test, you don't have a diagnostic test. Here we present a validated diagnostic workflow for 2019 nCoV. It's designed relying on close genetic relatedness of 2019 nCoV with SARS coronaviruses, making use of synthetic nucleic acid technology. Results, the workflow reliably detects 2019 nCoV and further discriminates 2019 nCoV from SARS-CoV. Through coordination between academic and public laboratories, we confirmed assay exclusivity based on 219 original clinical specimens containing a full spectrum of human respiratory viruses. What they did there was they looked to see if their test would, by chance, be not specific to 2019 nCoV, or as we now call it, SARS-CoV-2. They looked to see if it would accidentally test positive for other viruses. The control materials made available through the European Virus Archive, a European Union infrastructure project. Conclusion, the present study demonstrates the enormous response capacity achieved through coordination of academic and public health laboratories in national and European research networks. So the Germans had it, the Germans tested it, the Germans shared it, they validated it. We could have had a test January 17th in production on January 18th. This is the specificity test, the numbers of samples that they tested for other viruses. It was very specific, highly, highly specific. This was a very accurate test. If we get down to the results in the paper itself, well, let's talk about their test. Their test amplifies the DRP gene, it's the E gene, and the N gene. Let's look at the results. I'm just going to read this to you. They had determination of limits of detection of SARS coronavirus because they created samples of synthetic nucleotides that looked like SARS-CoV and that looked like the nCoV 2019 nCoV sequence. And they tested it to see if they could amplify it, even though they didn't have viral sequences. The specificity testing we talked about, cross-reactivity with other coronaviruses. They mixed into negative human samples. They took the DNAs from other coronaviruses and they put them into, or RNAs, I should say, RNAs, not DNAs. And they had very, very high sensitivity, high specificity, no false positive outcomes. No false positive outcomes for the Germans on their test. Discussion. The present report describes the establishment of a diagnostic workflow for detection of an emerging virus in the absence of physical sources of viral genomic nucleic acid. You don't need a sample to do this. The relative ease with which the assays could be designed for this virus, in contrast to SARS-CoV in 2003, proves the huge collective value of descriptive studies in disease ecology and viral genomic diversity. They could do what they did because people freely published their results in science. Real-time RT-PCR is widely deployed in diagnostic virology. In the case of a public health emergency, proficient diagnostic laboratories can rely on this robust technology to establish new diagnostic tests within their routine services before pre-formulated assays become available. And so CDC wanted their own test. And in many ways, you'll see on the data that I'm going to present to you, this delay cost us everything. It led to the shutdown. It led to people being kept home from kids being home from school and people not being able to go to work. It led to the panic and the fear, and what President Trump just mentioned. There might be more suicides from people losing their job. Please, if you have lost your job, call old contacts. We are a loving, caring species. Call old people that were used to be in their life and see if they have something that you could do for them working from home. Anything. Don't give up over this fiasco. If you need something, contact your local government and let them know that you can't feed your children. Don't let your children go hungry as a result of this. Don't go hungry yourself. If you need something, reach out on social media and just ask for it. Just ask, say, quarantine need, and make a request. No one's going to judge you. Please, let's take care of each other. It's very important for as long as we can. They wanted their own test, and then it turned out that some of the coronavirus kits that were shipped around the U.S. were flawed. This is February 13th now. So what happened here was that local laboratories were trying to use the test, and they found, because they had other tests that had been developed as well that were not yet given the emergency use authorization, that they got different results. They got a positive result in patients that had a positive, diagnosis based on symptoms, and a negative result in the Cdc'S test. That's a false negative. Anthony Fauci is someone who's going to have to answer for a lot of this too, because in his explanations in the rollout, he did not sound the alarm and say, you know what, you're right, that's a real problem. We need to get that German test online right now. And that's something that could be said today, 3/24/2020. Is it going to be necessary? I don't know, because the United States is not doing science. The United States is doing authoritative decree, truth by authoritative decree. Anthony Fauci's non-explanations include, it was a technical glitch that slowed things down in the beginning. Nobody's fault. There wasn't any bad guys there. It just happened. We're going to get into this. In an interview with Science Magazine, the big picture question was, we've all had this pandemic preparedness. Why did this fail? What went wrong? Anthony Fauci wants us all to wait until it's over before we ask questions. I'm not going to wait. You shouldn't wait. And look back when we can still do something now to make this better. When we look back before we can answer that. It's almost like the fog of war. Fog of war. You see that? Don't let that into your brain. Stop that right there. Throw those words out. They don't belong in your brain. After the war is over, you then look back and say, wow, this plan, as great as it was, didn't quite work once they started throwing hand grenades at us. No, Dr. Fauci, this would be like Northrop Grumman giving us missiles that don't fire, or worse, blow up when you mount them and arm them and kill our soldiers. It really is similar to that. No, it's not. Obviously, testing for the new coronavirus is one clear issue that needs to be relooked at. Okay, we're going to do that today. We're going to do this today, and we're going to look at it all week. Because everybody watching this video, I want you to share this with your elected representatives at the state level. I want you to share it with your elected representatives at the federal level. And I want you to share it with your medical doctors. I want you to share it with your loved ones and your family. Why were we not able to mobilize on a broader scale? But I don't think we could do that right now. I think it's premature. We really need to look forward. Really? In an interview with Hugh Hewitt on 3/17, this is not too long ago, Anthony Fauci was asked the question, what's going on with the test? He said, it was a complicated series of multiple things that conflated, that just, went the wrong way. One of them was the technical glitch that slowed things down in the beginning. Nobody's fault. There wasn't any bad guys there. It just happened. Hugh Hewitt. Go read the entire thing. And you can listen to the audio too, I think. And then when the CDC was told, and the FDA said both the system itself as it was set up, which serves certain circumstances very well. I don't know what that means. Why put in it serves certain circumstances very well? Okay, it doesn't. Certain circumstances, these are vague non-answers, was not well suited to the kind of broad testing that we needed the private sector to get involved in. The regulatory constraints, which if there were none, which under certain circumstances are helpful in protecting the American public, were not suited to the emergence of this particular outbreak. What are you talking about, Dr. Fauci? The CDC was given the first emergency use authorization. How long did that take? A day? You going to blame this on the FDA for saying yes? So there was a confluence of a bunch of things. This is a non-answer. I believe now that the CDC and the FDA and the department, and that we've got it right now because we're handling much of it over to the private sector, to heavy hitter companies that do this for a living. Do this for a living? Every person at the CDC involved in diagnostic does this for a living. The people who made the decision to make this test in the CDC first, instead of adopting the German test, they're going to cash their paycheck from that month. And they're making a living working at the CDC. So don't give me this because they do that for a living. And I think what you're going to be seeing looking forward is a major, major improvement to the availability of testing. Availability of testing is one thing, Dr. Fauci. Accuracy, sensitivity, and specificity are another. We're going to get to that too. Hugh Hewitt, was the glitch or anything about the production of the test President Trump's fault? Or actually, let me put it more broadly, would every president have run into the same problem? Anthony Fauci, oh, absolutely. This has nothing to do with anybody's fault, certainly not the president's fault. Unfortunately, there's a brave soul out there who stepped forward about the reality of what happened. There's a whistleblower, and this was an exclusive interview with James Rosen, Sinclair investigative reporter, and this was published Friday, March 20th, 2020. I'm going to read this to you. As the coronavirus spread to all 50 states over the last 2 months, right? The date again, March 20th, 2020. As the coronavirus spread to all 50 states over the last 2 months, the Trump administration faced mounting criticism for the lack of reliable, widely accessible test kits. Now, a former senior federal health official nominated to his post by President Trump alleges that the delays in testing occurred because leaders at the Centers for Disease Control, quote, lied, unquote, to the president, and that the Health and Human Services Secretary Alex Azar and to Health and Human Services Secretary Alex Azar about the center's ability to produce the kits. And so what this person's saying, this name is Chris Meekins, the former Assistant Secretary of Health and Human Services, in making these allegations for preparedness and response, decided private discussions he has held in recent weeks with top federal officials and physicians and scientists employed in private sector industries that are active in the anti-coronavirus efforts. Meekins described his contacts on the White House Corona Task Force as, quote, friends, some of whom he has known for years. From my conversations with members of the task force, this is Chris Meekins' quote, both inside and outside the administrations, Meekins told Sinclair's in an exclusive interview, the U.S. government, from Secretary Azar to the president, relied on the Centers for Disease Control to produce a test. They failed. CDC said they would handle it. What we have found out is that these leaders at the CDC lied both to the HHS secretary and by extension to the president. And as a result, the nation got weeks behind. He didn't say days, weeks, critical weeks behind. CDC has acknowledged that its initial stab at mass production of the test kits, we do stabs at mass productions, we just take we're going to try, encountered, quote, a problem, and that federal deployment of safe testing equipment lagged as a result. Safe testing equipment? No. The center's initial test kit carried the formal name Center for Disease Control and Prevention, CDC 2019 Novel Coronavirus 2019 nCoV Real-Time Reverse Transcriptase RT-PCR Diagnostic Panel. Okay, so that's very specific. And on February 3rd, CDC invoked public health emergency laws to petition Food and Drug Administration to allow medical professionals to make use of unapproved medical and diagnostic products that included these test kits. Okay, we're under emergency situation. We're going to break the rules. We're not going to follow regulatory procedures. And yet, we just heard Tony Fauci tell us that all the regulators, the regulatory red tape got in the way. FDA issued its approval the next day. With that green light, especially into the CDC, the International Reagent Resource, IRR, began shipping off the test kits. Shortly thereafter, CDC later disclosed laboratories started noticing performance issues with the test kits, and that the end result of laboratory personnel is, quote, not being able to verify the test performance. The core issue is said to be a defect in the manufacturing of one of the reagents, the center said. CDC is remanufacturing the reagents with more robust quality control measures. No, they're not. What they're doing is they're saying, use the test kit as we shipped it. Now, this isn't Meakin saying that. This is the CDC quote. The center's website noted. CDC is remanufacturing the reagents with more robust quality control measures. What they're saying is that we had 3 genes that tested. You're supposed to use 2 out of 3. Just use 2 because the third one's broken. The center's website noted, along adding that new tests would be distributed once this issue has been addressed. Okay, then Dr. Anthony Fauci, head of the National Institute of Allergy and Infectious Diseases at the National Institute of Health, widely regarded as the most experienced and respected expert serving on the president's coronavirus task force, said post-blank in a January 31 briefing, quote, we don't know the accuracy of this test. Commenting on the availability of test kits for other viruses that are confirmed to be 100% accurate, Fauci lamented, that's not even near what we have right now for the coronavirus. Well, we can say Fauci told CBS News Face the Nation last Sunday, that's not this last Sunday, but the Sunday of that week, is that, quote, now we have the private sector involved, we're going to see an entirely different scene that we've seen weeks previously for sure. Now, that article goes on with the CDC saying that 89 public health labs in 50 states are using the COVID-19 test. I'm not sure that's a source of reassurance to me. CDC rapidly developed a diagnostics test for CDC and the nation's public health labs, the statement said. No, they didn't. They developed a flawed diagnostic test. So what was wrong with CDC's test? Well, the first false negative that was attributed to a specimen that was mislabeled. There was a person that was released from Princess Cruise Line who later went on to develop a COVID-19 case. We were told that by the CDC that it was a specimen mislabeling. And then when labs started saying, wait a minute, your test is flawed, it turned out that one of the 3 genes didn't reproducibly amplify and they couldn't validate it. They got 2 sometimes, they got 1 sometimes, but they never got 3 out of 3. And so they started looking at other tests that were easy to develop. As you can see, you can make a test in a day. The question is whether or not are you a scientist? Are you going to validate it like the Germans did? And in making the comparison between these tests and that are not, approved tests, okay, they came up with different results. The RNA extraction kit turned out to be a limiting factor, we're told, which sounds patently ridiculous because we really at the time only had hundreds. We only had hundreds of cases when the problem was being rolled out. But in these kinds of rollouts, there can be a limiting factor. There definitely could be an unanticipated limiting factor. So I'll agree that RNA extraction is a very important part of this testing because you have to basically turn the RNA, pull the RNA out of human tissue, like a swab, cheek swab, feces, whatever you're testing. You pull that RNA out, and then you have to do reverse transcription to it, and that extraction is essential. But all the parts of the kit are essential, so you would think that in the emergency preparedness of a pandemic, they would expect that there might be an RNA virus. We certainly heard a lot about RNA viruses. We had experience about RNA virus. We had SARS in 2003. $11.9 billion a year? Almost $12 billion a year. The CDC wanted to market a test. They wanted to be the main player. They wanted to market a test, have hospitals use it, have companies use it. They could get it. They do license technology. We're going to get into that, but more importantly, they want to be seen as the authority that validates everybody else's stuff. Okay? They want to be the bottom line gold standard. They should have validated their own stuff first. But I heard also that they wanted to market a test that tested SARS, MERS, and SARS-CoV-2, and that would make it very complicated. So there must have been some discussions, or maybe that affected the way they chose their primer sets. I don't know. I've analyzed the primer sets, and I'm going to tell you what the results of that were. But there certainly are, by definition, an insufficient number of tests if you leave it in the hands of CDC. There's an insufficient amount of creativity and thought going into it because you have a limited number of people working on the problem. And if we know anything from 1985 going forward, is that massively parallel processing of a computational problem, and this is a computational problem at this time, this diagnostics, it's solved by including many players, not by having all of your eggs in one basket. And then there's the problem of false negatives. There's a coronavirus patient that was released in San Antonio on March 1st. Later turned up positive for infection. Why were they released? Well, there were 122 of them that were released, and some of them were false negatives on the CDC's test. Grand Princess Cruise disembarked all passengers, relocating, and they relocated them after the coronavirus cases. 3,500 were released. Unbelievably, they planned to drop the passengers off at a mall. And it wasn't until local authorities said, we don't want your 3,500 coronavirus cases. We want them to go somewhere else. So they put them on a military base. Well, okay. Why? Now, I understand that it's important not to let people get sick if you can prevent it. I understand that individuals have rights. And I'm a firm believer and fighter for individual rights. But at the same time, while those patients were on that ship, I very loudly suggested that all cruise ships be transformed into field hospitals, and that basically $1 billion be used to transform them into the world's most exquisite hospitals. But I'm just one guy, right? The availability of the test is a problem, too. Here's a statement by a quarantine nurse from a Northern California Kaiser facility on March 5th, 2020. As a nurse, I'm very concerned that not enough being done to stop the spread of the coronavirus. I'm currently sick and in quarantine after caring for a patient who tested positive. I'm waiting for, quote, permission from the federal government to allow for my testing, even after my physician and county health professional ordered it. At this time, March 5th, 2020, there were people in the healthcare industry who could not be tested because they needed permission from the federal government. Now, here we have Daniel Newman. He's an actor. The show was Walking Dead. Says struggles to get a coronavirus test. In reality, okay, if I can get this to play for us. I also want to notice that they see it says World Health Organization warns against using untested drugs. That's not what the story is about. The story is about Daniel Newman, the Walking Dead actor, struggling to get a coronavirus test. Okay, see, these two should be swapped. A little feedback there on perception control. Okay, and let me see if I can pull this up and hopefully it plays.
Have you considered how you would like
Sorry
to be
about the ad,
remembered?
folks.
Your funeral may be decades away, but planning your burial now is a great idea.
So very, very unfortunate
and financial burden of planning
commercial.
Your funeral. Visit burialplanning.com to get
Very,
a free
very
burial
unfortunate. I'm
planning
sorry
guide.
about that.
I really was not concerned initially. You know, I just had a cough. And then I started to have a little bit of trouble breathing, and it just progressed, but it still it felt like a cold or a flu. So it didn't really hit me until I'd heard that, you know, somebody in the group had tested positive. And so I immediately like anyone, you start thinking like, how many people have I just shook hands with? You know, we just did Mardi Gras with thousands of people and Sam Smith and Dua Lipa, and like, what in the world do I have? And just to be responsible, I started I called my doctor. He didn't have the test. Um, I called the urgent cares all over Georgia. Nobody had the test. And then they forwarded me to the health department, and the health department basically said, you know, just keep calling around. And it wasn't until I was able to find this one giant hospital in Atlanta emergency room. They went through all of the questions and asking me everything to kind of make sure that it was a fit. And then they were like, come in immediately. And when I got there, they took the temperature and all the vitals, and they were like, yeah, we have to test you. So $9,000 later, they were letting me know we need the ER beds and your symptoms are super mild. So the government has told us we are not even allowed to process your tests. And so they just let me and lots of other elderly and young people go home to self-quarantine without even being able to process the tests.
You were at one point nearly just turned away entirely, right? Until someone recognized you from your role on The Walking Dead?
I mean, that's disgusting. Yeah. At the entrance, they had a tent, and they basically were telling everybody after taking temperatures, you probably have a cold, you probably have a flu, just go home, go home, go home, self-quarantine. And yeah, it wasn't and preferential treatment is disgusting. The fact that our healthcare system is turning everyone away. And then even after I got tested and had this huge bill, they still couldn't process the results.
Okay, so let's dispense with that. And so there's not enough tests as well. And they start off all gung-ho and they want to do the testing and be ready to do testing. And instead of being able to do testing, they find out that there's not enough, so now they have to triage. They have to triage and prioritize people, and this is the beginning of what could turn out to be a very ugly situation in the United States, where people are being turned away from the hospitals that have deadly conditions and they need emergency care. They have deadly conditions, they need intensive care units. This is not a hypothetical, but it starts with the testing availability not being there, increasing the numbers, because we're going to get into the reason why we have to have accurate testing. There's both specific and sensitive issues about specifically testing this virus and getting a true positive and not getting a false positive, and sensitivity, which is being able to detect it when it's there and not getting a false negative. So when we look at other people like Dr. Messonnier and what she's had to say about this, I want to share this with you. The reporter, this was a transcript of an update by the CDC. You talk about the case count being low. How do we reconcile that with the fact that here in California, the most populous state, the governor yesterday said only a couple of hundred testing kits? And this is the core issue. How do you know the number of cases if you're not testing? The case count will be low because it sounds like there are enough tests that could reflect it. It seems like the issue of the math seems to be on a low count. Dr. Messonnier, that implies a false negative rate. Yes, thank you for the opportunity to talk about that. We need to remember that this situation is taking place rapidly. Another non-answer from a CDC official. By far, the majority of cases have been in California. A few weeks ago, we found an increase in cases around the world. Not relevant. She's buying time in this answer. She's on a conference call. And again this week, as we have seen an increase in cases globally, stating the obvious. Because of the aggressive U.S. efforts at the border strategy, a number of cases have been low. And we have been able to focus our efforts on travelers and their close contact based on our evaluation of who is at highest risk. No, you have not. You have not been able to track anyone that during a 4-day asymptomatic period. There are thousands and thousands of people that are interacting all the time, every day, every week, that had this virus. because they were let go, because they tested negative on your blood test. And we have been able to focus on efforts on travelers and their close contact based on our evaluation of who is at highest risk. We will continue to modify our approach. Sure. In terms of diagnostic testing, additional labs are coming online with additional test kits are on their way now. And the very next question, there's more problems with the responses and the non-responses. Hang on, a little technical glitch here. The reporter asks, I think a lot of us are grappling with a little bit here is the idea that China has been able to do tens of thousands of tests. Korea has been able to do thousands of tests, and here in the United States, in our local, we have done about 500, and our local patients are then plus another 2,000 patients or so have been repatriated. We just don't have the numbers they do in terms of numbers of tests. Can you explain that to us? How are others able to do thousands and thousands of tests that we have not been able to do them yet? Messenger replies, I think there are two answers to that question. One is that the epidemiologic situation in China and other countries is really different from the United States. And people breathe in China, and they shake hands, and they go to work, and they shop in stores, they travel in taxis, they make love to each other, they hug their children, they go to school, they go to work. I don't know what she's talking about. We acted incredibly quickly before most other countries. Really? That's an absolute lie. Aggressively controlled our border, and we were able to slow the spread in the United States. That was an intentional U.S. strategy, the goal of allowing us to control our efforts. So we have focused surveillance on those at the highest risk again. So, you know, we're looking at non-answers here from Dr. Messonnier. It's consistent with a pattern of really not being able to answer and give real answers. I have real answers, and I'm going to share them. This is, discussing scenario. This is the official CDC update, and we're getting these broad brush answers. They really don't mean anything. Our solution is part of, and is a huge priority in HHS leadership right now. Okay, but our solution, a larger part of any such infectious disease, is getting the test kit out. Really? Okay. We're gonna review if the CDC should be getting test kits out at all in the future. CDC has always had the capacity to test from the time rapidly when the sequence was available. And that there are two labs at the CDC doing the testing, and we have been testing aggressively the patients that state health departments have been referred to us. I'm sorry about the choppy reading, but the print on my screen is very, very small, so I had to amplify it. But so misinformation, incorrect information. The capacity of a lab to run a test has nothing to do with the accuracy of the test. The utility of the test is determined about whether or not you did science to actually validate the test. Now, February 29th, the FDA allowed local labs to develop tests, and if anyone at the FDA is working on this, then you're going to tell me there's a different story, that you never had a problem with other people submitting emergency use authorizations. But that's the way that this looks, that there was a priority to give the CDC a chance to get their test online first so that they could be the lab that validates other people's tests. And that's ridiculous. That's patently absurd. And it's the weakest link in the chain. That whole setup is the weakest link in the chain. It doesn't take a CDC to validate an RT-PCR test. It's ridiculous. Absolutely, patently ridiculous. The Germans did it with a network. The Germans did it with a collaboration of different labs. Okay, and that's the way that it should be. The New York Times on March 17th. This is not that long ago. Today's the 24th. U.S. lags in coronavirus testing after slow response on outbreak. So here is the CDC's massive effort to test. Okay. These are the number of tests and the number of cases. These are the number of tests and the number of cases in Italy. Italy's adopted the Germans' test, and they're all over it, but they still have high mortality. I can't imagine what Italy's mortality would be like if they didn't test. And here's South Korea, the winningest of the winning. These are other. Look at South Korea. That's what we want to look like right there. The number of cases came, and the number of cases went. And look at the massive amount of testing. All right, far, far, far more testing. Far, far, far more testing than cases, and that's a direct result. Because they're testing so much, then they can isolate people and shut down the number of cases. Because they're testing so much, there are few cases and therefore less mortality. Because they're testing so much, we don't see an exponential increase like we're still experiencing here in the United States. This is data from virusncov.com, it looks like, and in the United States. I'm going to compare now the United States and South Korea. These charts are nice because they plot the active cases and the recovered cases and the deaths, and that's just beautiful because it breaks it down so we can understand. Here's 50,000 active cases as of today for this data resource, about 50,000. The recovered cases, I don't see any recovered cases. I don't see any data on recovered cases. I don't see any data on deaths. Okay, but the scale, that's the scale that we have. There's so many cases, all right? And that's good. I don't want to see any deaths. I want to see recoveries, though. So where are the recoveries and where are the deaths? Right? That's a matter of scale. I'm sure if we zoom in, we would see more. This is what South Korea looks like as a result of testing. They peaked somewhere around 7,900 active cases, and then they bent the curve. And that's what it means to bend the curve down right here. And look at the number of recovered and the low number of deaths. Okay? This because they started testing right away. That's March 1st for them. All right? And March 1st for us was way back here. So we're looking at a totally different scale. If you did the logarithmic scale, you're talking 45,000 versus 4,000, 8,000. Okay? So, yeah, we're simply not doing proper effort here. And it's the lag is one thing. But there's other concerns about these tests we're going to get into. Like the coronavirus false test results. With the push to screen comes questions of accuracy. Reports of false negatives could complicate efforts. And that's the Mercury Times. Let's see. Well, one of the things that everyone should realize is that Dr. Wen Lang developed a cough and fever because he treated an infected patient. And he tested in China negative several times before eventually getting a positive result. And there's a quote here from Medication Junction. I want to give proper credit to it. Sorry about the mismatch about what's on. Well, let me bring that up. I want to go to this first. Okay. Are coronavirus tests accurate? On January 30th, the doctor posted, today nucleic acid testing came back with a positive result. The dust has settled. Finally diagnosed, according to the BBC. Dr. Wen Ling passed away on February 7th to Wuhan, the epicenter of the outbreak. No longer the epicenter, Europe. The next paragraph is very important in this article. False negative test results, where patients are told they do not have a condition when they actually do, cause several problems. Patients may be turned away from hospitals and medical facilities or cruise ships when they require care. They may infect others at home, work, school, or in the community. Patients' conditions may also worsen without treatment, and that is key. The reason we're being denied treatment for people that otherwise, if there's false negatives in this test, then we have a serious problem. In the test that's being used right now, we still would have a very serious problem. Okay, so and this is not anything that's new. We've known about false positives and false negatives in molecular diagnostics and other diagnostics for decades and decades and decades. The evaluation of a clinical test is very important. So this coronavirus false tests, the push to screen comes questions of accuracy from mercurynews.com. For a month, Rick Wright's life has been in limbo. More than a dozen times, the Redwood City man has been tested for coronavirus, and yet the results swing back and forth, never assuring them that he is or is not harboring the virus. I'm sitting in a holding pattern, said Wright, who never felt sick after being evacuated from the Diamond Princess cruise ship in Japan last month, but was quarantined at a San Francisco hospital for 8 days and then came home to protect his family and community. You're happy one day, then sad the next. You just want to be cleared and get your life back. He's not alone in this mystery. As testing increases, so do reports of inconclusive test results. And then I don't know where the next sentence comes from. In general, the test for COVID-19 is very reliable, especially in people with symptoms. I don't know what that means. What that is, like a confirmation bias. If you have symptoms and you get a positive, oh, okay, does that mean the test is reliable? No, that's only half the equation. Actually, it's technically 1/4 of the equation. Because as the article goes on, the specter of so-called false negatives, of wrongly telling people they're free of the virus when they're actually infected, looms menacingly over the effort to detect and control the disease as quickly as possible. Last Saturday, after testing negative, a Stanford student left campus by car and 5 other students, but on Sunday he learned that he tested positive, according to the Stanford Daily. I want to give you guys the dates. I want to emphasize the date of this. The date of this report, so I don't mislead anyone. Published March 19th, 5 days ago. So these people that are testing negative, testing positive, they're the ones that are, walking around feeling like they're negative. The ones that are negative, that they're infecting people because they're told that they're negative. Okay. In its official rules for testing, Santa Clara County Department of Public Health notes, quote, it is important to note that the test is not validated for use in asymptomatic individuals, and testing those without symptoms may give falsely reassuring negative results and lead to missed infections and inaccurate safety recommendations. The U.S. Centers for Disease Control and Prevention has not disclosed, 5 days ago, people, how sensitive its test is to detect very low levels of the virus. The Germans did. The Germans published that. The Germans published that, and the Germans taught the world how to publish that. When Dr. Anthony Fauci, the director of the NIAID, was asked about it in a recent interview in the Journal of American Medical Association, he hedged, quote, if the test is positive, you absolutely can make a decision. That's not another non-answer from Dr. Fauci. Okay. So you can look up that Mercury article and read the rest of it yourself. Let's look at the Centers for Disease Control and Prevention. Let's look at their website. On Monday, February 3, 2020, CDC submitted an emergency use authorization package to the U.S. Food and Drug Administration in order to expedite FDA-permitted use of the CDC diagnostic panel. They're going through some definitions of the EAU process. FDA issued the EAU the next day. IRR began distributing the test kits to the states, but shortly thereafter, performance issues were identified related to a problem in manufacturing one of the reagents. We talked about that. CDC is remanufacturing the reagents with more robust quality control measures. And the next sentence. I'm accessing this website live, and I'm reading it to you live right now, today. Excuse me. CDC continues to perform initial and confirmatory testing. They're using an untested test. The original CDC test has not yet been validated. New tests will be distributed once this issue has been addressed. CDC continues to perform initial and confirmatory testing. You guys are not going to believe what's coming next. What's coming next is the protocol for, how we're going to validate this. Here, go back one. And if I can scroll. I don't know if this is going to let me. No, it's a slide. I can't scroll. Later on in the website, it says serology test for COVID-19. There are serology tests, and we're going to talk about it. The serology tests at the CDC, well, there's commercially available serology tests. Antibody test, we're going to talk about that. Antibodies detected by such tests indicate that a person had an immune response to SARS-CoV-2, whether symptoms developed from infection or the infection was asymptomatic. And yet, here's the reality. If you're a commercially available entity, if you're a company and you have a serology test, you have to submit the results of that test along with samples to the CDC for validation with their unvalidated PCR test. That's in the United States today, 3/24/2020. My contention is that the CDC is not ready for any major outbreak whatsoever. We're going to take a look at what they did with Ebola and what they do right now with Ebola. Here's what a person has to go through with a clinical sample if they suspect Ebola virus. They have to have the infectious substance in a vial that's capped with absorbent packing material. It has to be wrapped in one container, put in another container with a lid, and put in a box. All right, and it has to be shipped like this. That's fine if you have one sample. Most laboratories can do that with one sample, but in an outbreak where you have hundreds of samples or thousands of samples, all of the labs around the country are busy packing up their samples instead of doing local testing. If you have thousands, what about 10,000 samples? Is CDC capable of handling 10,000 samples? No, they're not even capable of tying their own shoes. They can't put a test together. High school students can put RT-PCR tests together in the lab. I'm sure of it. If you go and you look at the guidance for the collection, transport, submission of specimens to Ebola virus testing, why in the world are we sending samples to the CDC for validation? That's why we're doing it. Because you may have a perfectly good molecular biology lab or a BSL-4. Okay, fine, it's a BSL-4. We've got to take care of it. We've got to make sure that nobody gets sick. It's Ebola, for crying out loud. But what if the CDC's test for Ebola is as good as their test for coronavirus? And all that handling and packaging and wrapping, and you're already in the room with the person sitting right next to you that might have Ebola. Specimens should be obtained when a patient meets the criteria for person under investigation, PUI, including patients with clinical signs, symptoms, and epidemiological risk factors for Ebola virus disease. I have a history with the CDC on Ebola testing. I was the director of the Ebola Rapid Assay Development Consortium, managing director. I'm a humble person, so I made myself managing director to try to help make it happen. In 2014, 2015, I was working with 3 universities who all agreed to work with me at the onset of my non-academic career as a free and independent scientist. And we were designing, using computer models, proteins that would bind to the Ebola surface antigen, surface protein. And this test was a colorimetric test that would wick saliva into a jar. So the protocol for laboratory screening would be a person wearing gloves doing laboratory screening would hand the jar, a small vial, to each person coming off the plane, or the airlines could give them to them. They could be in the test could be distributed on the plane, and the individuals could be instructed to put it in their mouth for 15 seconds and wick saliva, and then put the vial into a plastic bag, seal it, put it into another plastic bag and seal that, and then hand it to whoever they're supposed to hand it to when they disembarked. The vials would then be gone through before anybody could leave, and the ones that turned pink, those would be the ones that would be retained as persons under interest. Now, I called the CDC because we were going to be close to a prototype, and the prototype, we couldn't test it because we don't have a BSL-4 laboratory. So I asked CDC would they test our prototype, and they said no. It was an outright rejection. And I said, why? I told them who I was working with: UC Santa Barbara, UIUC, University of Illinois Urbana-Champaign, Penn State University. I was working with some major hitters here. Stanford, I think, was involved for a little bit. And Their answer was no. And I said, why? They said, well, because we have our own RT-PCR kit. And I said to this man, whose name was Stuart Nickel, I had read his research papers, and I knew the viremia in the body, when the viremia is higher with a large viral load, that the Ebola virus was present in saliva. I said, but for PCR, you're doing a blood draw, right? He said, yes. I said, you're going to do blood draws in the airport for airport screening. And he said, I'm sorry, we're not going to test your prototype. Later on, I was invited mysteriously to a secret White House conference call. Some colleagues of mine, multiples, sent me their copy of an invitation letter. And that White House conference call was interesting because the Ebola czar at the time, Ron Kaiser, said that, listen, we want you scientists that are out there in the community, you need to say what the CDC says. The community trusts you, and we don't want you to instill fear in anyone. And he then said, because we have this nice NIH funding mechanism, and basically it's a shame something should happen to your NIH funding. Well, I didn't have any NIH funding at the time, and I had already left the University of Pittsburgh, and I was on my own. And I asked, there was a question and answer session at the end, and the question and answer session went like this. The first person that asked a question said, when you guys went to the West African countries, the NSF has actually been funding sociological and geopolitical research in these West African countries for the past 25 years. Why didn't you get a hold of us? And we could have told you who in those communities you should come to, so you didn't scare everybody to rush off into the jungle when you showed up with your spacesuits to test everyone. Ron Kaiser said, well, that's an interesting idea. Maybe we'll do it next time. I asked my question. There were a couple of other questions intervening, and my question was, could someone please explain why the director of the CDC, Tom Frieden, who was the director at the time, testified to Congress, a congressional committee, that when he was asked by a conservative representative, was he concerned that there were going to be any outbreak in the United States of Ebola? And he said, no, there's not going to be an outbreak in the United States. I'm not concerned because I would only be concerned, he said, to be accurate on the quote, if there was a mutation in this virus, and there are none. And I nearly spit my coffee out because I was analyzing the exact sequence data, comparing Ebola from 2014 to Zaire Ebola in 1995. And there were 396 mutations. And New England Journal of Medicine had published that there were 396 mutations, and I was validating and looking at the specific nature of those mutations. So he was misinformed. And so I had asked the question on this White House conference call, hey, could someone tell me why the CDC director is saying there's no mutations in this virus? Somebody misinformed him. I think he needs to be informed that there are mutations in this virus. And the question went to somebody from the CDC because nobody else could technically answer it. And the person answering the question was Stuart Nichols. The person that told me that CDC wanted to advance their own test, a PCR test. And I suspect, although I don't know, that the reason why they needed the virus to be 99.999% similar, which is what Stuart Nichols actually said on the conference call. He said, there's not mutations, that's ridiculous. He said this virus is 99.9999% similar to the virus from Zaire. Now, it's just a matter of math. When you're comparing DNA sequences between two species, it's very elementarily simple. It's trivially simple to compare the sequences using a BLAST algorithm. The BLAST algorithm was invented by one of my postdoctoral mentors, Webb Miller. I had obviously used BLAST. I use BLAST today. And he lied. And I can only imagine that he was lying because he wanted they have this paradigm that, no, this is the same thing because their PCR kit used primers matched to Zaire or something like that. That's a suspicion. But nevertheless, with all this packaging and shipping to CDC for validation by what? By CDC for Ebola? I'm very skeptical, especially if we have an outbreak where there is this kind of massive hyper exponential, but increase. How is the CDC going to handle the throughput? They can't even tie their own shoes in a molecular biology lab. That's a serious problem. The safety of the United States is dependent on the bioweapons. The safety of the United States is national security is dependent on this setup. Okay, where CDC is supposed to validate everybody else's test. Well, I've been in other laboratories around the country, and I've worked in other laboratories around the country, and many of my colleagues are in laboratories around the country, and there is far more talent and creativity in the commercial and in the university laboratories than there is in CDC. Why is the CDC held up as the gold standard? This is unacceptable. It's impractical, and it's the wrong strategy. CDC can't even count the number of deaths from influenza properly. They say that there's more than 80,000 deaths in 2018. Where they got this from, this National Foundation for Infectious Diseases press release about this meeting that they had on September 27, 2018. So the 2017-2018 season is what we're talking about. They claim that there was more than 80,000 deaths here, 900,000 hospitalizations, and this is why people are saying COVID-19 is not a big deal. Look at influenza. Okay, here's the problem. For 10 years, from 2009 until 2019, the CDC website on this matter read as follows: CDC conducts surveillance for people who see their healthcare provider for flu-like illness. What about the people who don't see their healthcare provider, right? Through the outpatient influenza-like illness surveillance network, a network of thousands of healthcare providers who report the proportion of patients seeking care for flu-like illness weekly to CDC. The system allows CDC to track levels of medically attended flu-like illness over the course of the flu season. CDC does not know exactly how many people get sick with seasonal flu each year. For 10 years, they had this on their website, till two health freedom activists, Ali Fugito and Bernadette Pager, Ali from the Pennsylvania Coalition for Informed Consent and Bernadette Pager from Informed Choice Washington. The specific quote was put on social media by Ali, I think, and it says, in fact, when we actually checked the data, we learned that people whose deaths were reported as influenza deaths were not laboratory confirmed as even had influenza, let alone having died from influenza. All the final death numbers in CDC's National Vital Statistics reports, final death data up until 2016, always separated influenza deaths from pneumonia deaths. And for darn good reason, most people who have pneumonia do not have influenza. When you see 80,000 deaths from flu, they're talking about pneumonia plus flu, whether or not they have influenza virus in the first place. Okay, so there are many, many causes of pneumonia other than influenza. And Bernadette did her own legwork too, and she actually got this started. She wrote to CDC, and CDC in an email to her had written back, CDC does not know exactly how many people die from seasonal flu each year. And they give their litany of reasons. Okay? Now, if you go to the frequently asked questions of estimated burden, flu burden, right? And this is what we're talking about here, the influenza A plus B. This is the number that they report in terms of cases. They don't know the number of asymptomatic cases, the people that don't show up for medical care, but they use modeling to try to estimate it. And they get paid $12 billion a year to do this. They can't even count it right. But if you try to go to this webpage right now, this webpage is gone. It's been taken away. It was, I think, July of last year it was terminated. About the time that these health freedom activists started asking questions about this practice. So now we're just being told what the numbers are, and we're not being told the CDC doesn't know. And this is a problem, because the CDC doesn't know. Their job is surveillance. Their job is an incredibly important job. This is the 10-year period from 2009 till about 2019. Well, the queries from the community were in 2018. And in 2019, they stopped disseminating the truth which is what they don't know, the number of influenza cases. Oops. Can't seem to find the page. I lost the keys to the factory, folks. Thank goodness for the Wayback Machine. The CDC can't even count the number of influenza cases, right? So we're supposed to trust them with tracking and surveillance. We're supposed to trust them with testing. We're supposed to trust them with our very lives, our livelihoods, our prosperity, our health, and our freedoms. Well, it turns out that the medical community doesn't really trust the CDC after all. New York's making its own. UPMC announced they're making their own and doing studies. And that's the important thing. That's the distinction. To my knowledge, CDC has no data on the sensitivity and specificity of their test. See, if you get a test, regardless of the nature of the test, it could be a radiological assay, it could be a lateral flow assay, it could be a PCR test, it could be a symptomatic diagnosis. There is the ability to detect an illness or a condition. So the proportion of correct diagnoses that are out there, where you say, yes, this person has the condition, a positive diagnosis, that's sensitivity. That's the ability or the power of the test to be able to detect something that's really there. Its specificity is the ability to say it's not there when it's not there. And there's usually a trade-off. In a very accurate test with 100% accuracy, you have 100% sensitivity and 100% specificity. The Germans calculated an estimate of their sensitivity and specificity. They have a reasonable scientific approach to this. The CDC threw a bunch of primers together, shipped them out to everybody, and just, okay, let's see what happens. And they're the gold standard for the United States. I'm embarrassed. I'm absolutely, abjectly embarrassed. And when I saw UPMC do this, I was proud. I was proud that UPMC is doing it. I live in Pittsburgh. I used to work with UPMC. I used to work in a UPMC building at the Cancer Center, UPCI. I was at the University of Pittsburgh. I was proud that they were taking this on. They weren't waiting around for the CDC to continue to screw this up. There's this lateral flow assay that's out there too, and I'm going to go into some detail about this lateral flow assay. What a lateral flow assay is, it's a immunoglobulin test. And this is an important test. It's by Biomedomics, and I downloaded this on March 15th. They published it on March 15th. Basically, you take a sample from a person, and you put it into the assay. The assay gives you a reading, and you have your result. You get the blood, serum, plasma sample, okay? Not a problem. Easy to do. People can do it at home. Okay, you collect the blood, serum, plasma sample, you add the blood, plasma, serum to the sample well, you place 2 to 3 drops of buffer in the sample well, you read the results after 10 minutes, 15 minutes later you got a result. You take a picture of it, you send it to your doctor. That's what I suggest we do. Okay, but that's not how we're set up. Our nation is not set up to use biomedomics. All right, here are the results. If you're negative, it's a single line. It's just like a pregnancy test. If you're IgM positive, it's this way. If you're IgG positive, it's that way. If you're both positive, it's here. Guess what they have? They have sensitivity and specificity characteristics of this. They've done their research. All right, there's the technical test principle, how it works. Okay. It's precise. It's validated in their lab by PCR. It's already pre-validated. You see the difference between real scientific pathology, that's what this is, diagnostic pathology, and whatever it is that CDC is doing while the rest of us are waiting on them. It's fast, 10 to 15 minutes per test. It's an intuitive visual interpretation, and there's no special equipment needed. In order to test the detection, sensitivity, and specificity, test science of the COVID-19 IgG IgM combined antibody test, blood samples were collected from COVID-19 patients from multiple hospitals and Chinese CDC laboratories. The tests were done separately at each site. A total of 525 cases were tested, 397 positive, clinically confirmed, including PCR tests, SARS-infected patients, and 128 non-SARS-CoV-2 infected patients, 128 negative. The testing results of vein blood without viral inactivations were summarized in Table 1. Of the 397 blood samples from SARS-CoV-2 infected patients, 352 tested positive. Now, it's not perfect, but it has a sensitivity of 88.66%, and that's pretty good. In terms of, a first pass at this, these are the people that don't have sufficient viral load, or there's something different about their immune system. It's pretty good, right? But it's a 12% false negative test. See that? So 88% is about 11 or 12% false negative. We don't want false negatives. So this test should be improved upon. 12 of the blood samples from the 128 non-SARS-CoV-2 infection patients tested positive, generating a specificity of 90.63. So there's about 10% false positive rate. Not bad for only being out March 15th. That's kind of remarkable. So here's what would happen. The people that tested positive, 88% of them would be triaged and sent home. Now let's do some modeling. If there's a 10% false positive or 11% false negative, right? And then they were continuously tested because they were in contact tracing, or they were in contact or in a household that had it. Eventually, when their immune system kicked in, they would likely test, positive. So you would have clusters instead of a national outbreak. 12 of the blood samples of them tested positive. So 10% of the people tested, would they be at risk of having to be quarantined? Well, not unnecessarily. That's not 100%, is it? If we use this test on 100% of the population right now, there'd be 10% of the population under quarantine unnecessarily, and another 10% walking around that shouldn't be. That's a lot different than everybody walking around, though. A lot different. So, I really recommend that we look at in-home testing. The test kits should be sent, and they should be acted upon. Now, here's the problem in the United States, and this performance evaluation from Biomedomics. Their website also says, unfortunately, a negative result doesn't allow us to say you're truly negative, and they're being forthright about it, but they know it, and that's the difference. I don't know the sensitivity and specificity of the Cdc'S test. I don't think anybody does. It's never been published to my knowledge. I've asked for it, and we're going to get into that in a little bit more detail, but at least you get the testing done, and if you're positive, you are given the instructions on what to do, and that's the difference here. Think about it, we could get 88% of the people that are positive off the streets. That's how you have to look at this, right? Now the kicker is, and you guys are not going to believe this, the way that the laws are written right now, the way that things are set up, if this test tests positive or negative, other samples still has to go to the CDC for validation with their PCR test. It's patently foolish. Wasteful. It's a waste of resources, a waste of time, a waste of money to take a validated test result and validate it with an unvalidated test. What does the CDC say about this? Is Dr. Messonnier on February 28th. February, folks, last month. As more cases have been identified and more cases have been available, it is clear that 2 of the 3 reactions, we actually are appropriately sensitive and specific in identifying cases. Show us the data, CDC. Show us the ROC curves, receiver operator characteristic curves. Show us the tests on artificial samples like right? I don't even want you to do that. I want you to just pack your bags and go home. You don't belong in the game. You're redundant. This is further from the original transcript that I read to you for Dr. Messonnier. Right now, labs can start testing with existing CDC tests. So what? So what if they can start? We don't know what it does. We have no idea what it does. Just because I can start up a race car doesn't mean I know how to drive it. States that were able to validate their kits should continue to test in this manner. What? So as long as it looks okay in your lab, if our kit looks good in your lab, go ahead and continue using it. No, we're going to abandon your test because it's failing somewhere. Okay. States that were able to validate using only 2 components specific to novel coronavirus can test using only those 2 using revised instructions developed at CDC, made up as they went along. Unvalidated. subject to confirmation bias. We have established that the third component, which was the cause of the inconclusive results, can be excluded from testing without affecting accuracy. We have been working with the FDA, and they agree with our approach. While we're working to amend the existing EUA, Emergency Use Authorization, FDA should pull it. FDA needs to pull that authorization. We have discretionary authority from FDA to proceed in this manner. This will increase testing capacity with an unvalidated test at state and local health departments with an unvalidated test. All positive test results will continue to be confirmed by CDC for some time. Why? They're using your test. You don't validate your test with your test. That's not validation. This is utterly foolish. Molecular pathology doesn't belong in the hands of these people. Additionally, CDC has manufactured brand new test kits that will only include the two components and that are specific to novel coronavirus. In other words, they were trying to corner the market on coronavirus testing. Those test kits are at the International Reagent Resource, where orders can be placed. We are working as quickly as we can to get CDC test kits to state and local public health authorities. However, during any infectious disease response, there's a great need for test manufacturers to rapidly make testing available in clinics, in hospitals, and at the bedside. In other words, this is CDC speak, okay? Right here, I'm going to invent a new word here. It's called CDC speak. However, we acknowledge that the manufacturers are probably going to make their own tests, and we're okay with that. Nobody asked you your opinion. We're going to go ahead and do it anyway. This is part of a huge effort within the U.S. government, but led by HHS? Not really. No, not really. I don't think anybody in their right mind would ever send a test to CDC to be validated from this day forward. You'd be crazy. And please, when you share this video, molecular diagnostic laboratories would be crazy to send their samples to CDC to be validated. Crazy. This, for completeness, was the date that FDA so-called relaxed their restrictions on non-CDC testing. CDC doesn't have a choice in the fact that the world's moving on from them in terms of testing. But if we go back to the biomedics, look at PCR nucleic acid test versus biomedics rapid test. The turnaround time is greater than an hour. Yeah, right. They're being nice. The PCR tests take greater than an hour, and then you have to send it to CDC to be validated with a PCR test. 15 minutes. Stay home or don't. Okay. Facility requirement, PCR laboratory. You could do this in your bathroom. Requires trained technicians, whole blood, serum, plasma. Just poke your finger. Requires like a prick for sugar testing. No big deal. Requires expensive equipment. It can be used anywhere, including airports. Complicated operation. No specialized training required. Prone to false negatives. Results are clear and easy to read. Requires cold chain, room temperature. You don't have to have a special PCR machine. Commonly used gold standard. That doesn't mean anything anymore. The gold standard is tarnished. The gold standard has turned out to be painted lead. Highly specific, can detect silence infections. Okay? Because they've done their research, they've done their science, right? We want public health policies based on science. I've been saying it for 4 years. This is the address for Biomedomics, and I have no financial disclosures, no relationships with Biomedomics. So they're in Morrisville, North Carolina. This is not a paid endorsement. There is no quid pro quo. Let me say it slowly. And to find out more, 919-890-3070. Make this go viral. Send it to your doctors right now. Send this to your doctors. Write this down. I'll leave it up here for a while. Take a picture of it with your phone. If you're watching this on the computer, come back to it and note the time in the broadcast. Biomedomics. I don't know this company from anyone, but I do know that this test was used in China, and China has ended their outbreak. Okay? So, I've been in contact with the FDA about this, and specifically Timothy Stenzel, about the CDC's performance evaluation. I wanted to know, are there evaluation measures? Is there a sensitivity measure? Is there a specificity measure? And I sent the FDA my own results of looking at the CDC test components to see if they matched human proteins. There's some positive controls in there that have to match human proteins, but I was concerned over some of the results that I saw, so I sent it along. And I've notified the CDC as well about what I found. And I wrote to Mr. Stenzel to find out where the performance evaluation measures of the CDC PCR COVID-19 tests are. I did this today to make sure it was updated. I waited till the last minute. This was just minutes before I went online, and I got this result back, this reply back. Well, a couple hours. I guess it was 12:25 p.m. And it's they sent me a link. Tim sent me a link to the EUA letters for all of the people, all of the companies that have EUA letters, okay, for their tests. And I went through and I read each letter. There's a good number of them. I think there's about 18 different companies that are making PCR tests. And I did note that some of the letters went out with requirement of negative controls to assess off-target amplification, including PCR, including the PCR test by the CDC. And I asked him if there was any testing done similar to that was provided by the German test, by the Germans for the CDC's test and these commercials test. And this is where I became an advisor here. I would strongly advise that you recommend to each manufacturer to conduct such testing as they proceed with their rollout to avoid further delays and problems. I apologize if this is already a requirement. We are not at the place where we have a validated CDC test. How can they validate the results being sent to them? This is criminal at this point. And if another CDC employee says to anyone, to Congress, to a congressional committee, to the press, to anyone, that they can validate other people's tests, they have to show the data. I need the sensitivity and specificity so we know what we're talking about. It's absolutely criminal from this point forward. And Tim wrote back and he said, I've shared your comments with our team. Thanks. So what I'm asking for is science. I'm not imploring. I'm just asking that they actually conduct science on these PCR tests. Because what we're seeing is problematic. This is a resource. I didn't steal that image. It actually came from a resource that I have the link. And by the way, there's a companion article on my blog website, jameslyons-weiler.com, that will have all the links to all of this. And I'm going to publish it right after this presentation. But there's 290,000 total tests as of today conducted in the United States, and over 90% of them are negative. But the question is, how many are false negatives? And until we know that, we really don't know whether the test is helping us or continuing to harm us. The CDC, remember, wanted their own test, and they were already given data about the performance of a test that was just like theirs. It was the PCR test. They could have adopted it like 60 other countries did, like South Korea did. They could have adopted it. We could have been testing back in March, early March. All of the new cases of coronavirus 19 that have happened, and all the deaths that have happened from those cases that were not found by tests, fall squarely on the shoulders of the people of the CDC that made the decision to have their own test. That's why IPAC, the Institute for Pure and Applied Knowledge, of which I'm the CEO and the director, has issued a biodefense strategy statement on 3/23/2020, the current situation in terms of the exponential increase in the number of cases of COVID-19 and deaths from the infection, the lost opportunity for the medical community to be ready, school closures and the isolation in place, the loss of income, general disruption of how our society functions, and the awesome losses in the private sector were all utterly avoidable and can be traced directly to the CDC's decision, which it continues to make to refuse to adopt an already validated test from Germany. The fact that the public and the medical community alike have, even now, not been told the exact nature of the flaw or flaws in the CDC's test is utterly unacceptable, profoundly unacceptable. We are deeply concerned that false negatives continue to drive the rate of spread of SARS-CoV-2 in the United States. We urge all laboratories to use validated non-CDC test kits. Do the science yourself. Do what the Germans did. Get a hold of the German study, it's peer-reviewed, and replicate it. These events demonstrate that the centralization of risk detection, surveillance, modeling, diagnostic testing, and public health policy in one location with one culture with limited human resources places U.S. national security at risk. These events have proven CDC to be unskilled, unresponsive, redundant, and in reality a dire threat to public health during a pandemic in which accuracy and timeliness of responsiveness is critical. Major U.S. universities and hospital systems all house talents in diagnostics that are vastly superior and that are also, by definition, more diverse. Decentralization of public health responsibilities is highly recommended. For reasons related to national security, CDC should no longer promote its test, nor should it serve as a centralized validation center for testing for infectious diseases. Those involved in the decision to refuse the validated test from Germany should resign. Those who have misinformed the public and Secretary Azar, thereby the President of the United States, should resign.